without taking much time, debates are whenever there's a gray zone where we are not coming to a conclusion, we debate. So that's why we are taking this topic where there is a role for pharmacotherapy, like bariatric surgery in adolescent obesity. Now for this, to say yes, I asked Dr. Ravikumar to come to the dais and just put this note to address the public that pharmacotherapy is a must in these population, because obesity as such has got two phases. One is a cosmetic phase and another is a functional state. Where cosmetic, there are some problems, and functional means it causes metabolic and other morbidities. So that's the reason why we are concerned whether there is a role for pharmacotherapy or not. So I request Dr. Ravikumar to proceed.
Thank you very much, sir. Good afternoon to everyone. So, as a speaker for the role of pharmacotherapy and bariatric surgery, first of all, I thank the organizers for a wonderful topic, and then we'll go into the topic. So, first of all, we'll talk about why pharmacotherapy. The basic reason is there's a practical reality that management of childhood obesity is not easy and it's not very rewarding. It doesn't work. That's the truth. So, first of all, we have to accept the truth and face the reality. So, even after counseling a number of times and spending nearly half an hour every time in the clinic, they don't seem to follow the guidance you give. Diet control, exercise doesn't seem to work. So that is the basic reason why we're looking into pharmacotherapy and the role of bariatric surgery. Number two is there's a high risk of complications, metabolic complications, as we all know, impaired glucose tolerance, diabetes, dyslipidemia, sleep apnea, and all these. And adolescent boys and girls especially seem to be more prone for this, especially Asian population. So studies have shown that university-based clinic, 1/3 of obese teenagers with profound insulin resistance and IGT develop type 2 diabetes despite regular lifestyle counseling during a follow-up of 21 months. So at least in college-going students, it doesn't seem to work, whatever the intense counseling that we seem to give, lifestyle modifications. Number two is in adolescent age particularly, up to 60 to 80% may have rebound increase in weight once they stop coming to the clinic, once they stop the lifestyle modification, whatever the intervention that we advise them, once they stop it, there's a rebound increase in the weight. That's another reason. So it's very clear that we effectively have to intervene to prevent long-term complications in these children, and there's just no way we can just wait and watch. Why not lifestyle intervention alone? Is there any physiological basis? So weight loss is difficult for most patients, as we already considered. The patients decide to restrict the food and energy intake is counteracted by adaptive biological response. The body then reacts. There's a physiological response that comes in, adaptive responses to weight loss. So which way these adaptive responses work? Basically, there's a reduction in total energy expenditure when weight is gone down, that is out of proportion to the lean body mass. Basically, which means that these individuals have to keep on doing exercise, intense exercise, to reduce the energy to increase the energy expenditure so that they can maintain the same weight. So physiologically, we know that that is how it works. Now, why not lifestyle intervention alone? The intense lifestyle modification therapy, intense exercise and other things have to be continuously done in highly motivated subjects, only then it works. If we do moderate intervention with specific caloric guidelines and exercise counseling, it is less effective. If we do standard lifestyle approaches, they have little or no effect. And also rebound weight gain in both intensive and moderate groups happens so frequently that after a while it seems like it's a futile exercise, no matter how much time you spend with them. So let us see what the Endocrine Society Clinical Practice Guidelines say. These are all displayed on the website, 2015 guidelines, Pharmacological Management of Obesity and Endocrine Society Clinical Practice Guidelines. Now the guideline says that patients who have been unable to successfully lose weight and maintain a goal of weight may be candidates for prescription medication. Medications and bariatric surgery can be combined with behavioral changes. What it recommends is pharmacotherapy when the BMI is more than 27 with comorbidity or BMI more than 30 without comorbidities. And surgery can be considered if BMI is more than 35 with comorbidity or BMI more than 40 without comorbidity. So further in the guidelines, it says if a patient's response to a weight loss medication is deemed effective, that is weight loss more than 5% body weight and safe, we recommend that the medication to be continued. In obese patients with type 2 diabetes requiring insulin therapy, we suggest adding at least one of the following: metformin, pramlintide or GLP agonist to mitigate the associated weight gain. And further in the clinical practice guidelines formulated by the Endocrine Society, these are all the drugs that are mentioned, including phentermine, which seems to be promising now, topiramate phentermine combination, lorcaserin, orlistat, natrexane and the bupropion combination, liraglutide. These are all the drugs that are mentioned. Of course, none of the drugs are wonderful and but they all have a role to play. And some of them are more expensive, some of them are less expensive, some of them have side effects. We all have to think about it. Not that we can't just rule it out that there's no role for pharmacotherapy. And looking at, apart from the guidelines, there are several studies done, and we'll just go through one by one. So this study shows a weight loss, let us say the orlistat group and the metformin group. So up to 2.5 kilograms weight loss can be expected in a year's time, and that too with a very high attrition rate. As in orlistat, attrition rate is as high as 30 to 35%. The other one, sibutramine, is probably one of the best, but we cannot use it. It's been withdrawn voluntarily. And rimonabant is now no longer used because of the psychiatric side effects, so we won't consider that. Now the same study, if you see the top line, the standard treatment in children, if you see lifestyle intervention, hardly results in any reduction in the weight change. The weight change in the y-axis is actually standard deviation, so there's not much change as you can see. But the next group, some metformin, there's some change in the weight loss. Next, orlistat, sibutramine. So subsequently, other drugs have some effect at least. So as you can see in this slide, lifestyle modification has very low effect in some group of patients. So let's go through briefly the drugs and classification. Centrally acting drugs, phenylpropanolamine, phentermine, amphetamine, flenfluramine, sibutramine. There are a lot of side effects on these medications. I'm not coming into that. But let's just go through the classification, because in future, there's no point just working on them lifestyle. Basically, practical reality, it doesn't work. Next combination is those which are in development, the drugs group which are in development, recombinant human leptin, which we know that it's a wonderful drug for leptin receptor defects. Metroleftin, that group of drug, works beautifully for leptin receptor defects. Bupropion, lorcaserin, fluoxetine, topiramate, pramlintide, liraglutide, exenatide, sitagliptin. So these are all the candidate agents which are being tried. And drugs affecting nutrient trafficking, that is orlistat, cetylistat, acarbose, so such group of drugs. Next, the drugs that affect the metabolic control, like metformin, octreotide, recombinant human growth hormone, thyroid hormone, ephedrine plus caffeine combination. And now this combination drugs, novel combination therapy is in development. Phentermine and topiramate combination, bupropion and zonisamide combination, bupropion and naltrexone combination. So similar pramlintide and phentermine combination. These are all novelly created combinations to try, and some of them have been very promising. Again, the American Diabetic Association group classifies these kind of agents into according to what the mechanism of action. If you see the food selection, appetite and satiety, sibutramine and rimonabant, metformin also to some extent. Nutrient absorption, orlistat. Fat storage and distribution, metformin, rimonabant. Insulin sensitivity, metformin. So again, insulin sensitivity and expenditure, metformin, sibutramine. Insulin production, metformin. These are the drugs and how they act. In one study on orlistat, well, several studies are available, and they've all used a different type of doses. On the right-hand side, you see the outcome. Uniformly, they've had achieved about 2.5 kilogram plus or minus kilogram per meter square. Change in the weight, the BMI change, that is the delta BMI, they've achieved within the first year. Now coming to, is there a role for metformin in the treatment of childhood obesity? Again, several studies are available. Some of them have documented some promising results, but not great, I should accept, but still there is some result which is better than pure lifestyle modification alone. This is from Paul Kaplowitz, 2017, from Washington, DC. 85 adolescents with obesity aged 12 to 19 years with a documented insulin resistance. 60 received metformin at doses escalating to 85 milligrams twice daily by 2 months. 25 got a placebo. Metformin group had 23% reduced BMI reduction of more than 5%, was achieved by 23% of individuals. whereas in placebo group, 0% achieved any reduction in the BMI. So none at all. Role of metformin in preventing type 2 diabetes in Asians. See the last column there, that's the Asian Indians. Compared with the standard, that is standard is no pharmacotherapy, only on lifestyle modification. And the next group is metformin. You see there's a 26% reduction in the cumulative incidence of diabetes. So it's fairly good in controlling, in preventing the development of onset of type 2 diabetes in those with obesity and impaired glucose tolerance. Phentermine, what is the role of phentermine? Long-term prescribing of phentermine, of course, the questions arise, ethical questions. Is it reasonable to give these kind of drugs? What about the local laws? What is the ethical laws? What is your legality-wise, where you stand? All those have to be looked into. I'm not denying that. But still, if you see in USA, it is the most widely prescribed weight loss medication, off-label prescription. Addiction potential is low. And 15 milligrams phentermine, over 7% weight loss at 7 months is achieved. Phentermine plus topiramate was approved by FDA in 2012. Topiramate and phentermine as an adjunct to diet and physical activity for those with a BMI of more than 30. It's been tried, it's been approved. Now coming to, can we identify pediatric candidates for pharmacological therapy? So these are the criteria we can use. Family history of early onset glucose intolerance or cardiovascular disease. Children with severe insulin resistance, IGT, hepatic steatosis, ovarian hyperandrogenism. If diet and exercise fail to achieve medical objectives. In theory, basically to prevent the progression of severe obesity and metabolic complications. Off-label use of drugs approved for other indications for chronic obesity management. This is what the Endocrine Society Clinical Practice Guideline says. Now we have to understand, right now we have a very limited group of drugs, so we cannot make any recommendations. But the future is this, because we know very well the lifestyle modification doesn't work. So in future, we have to work on these drugs plus or minus bariatric surgery. So trial of such therapy can be attempted. That's what the the clinical practice guidelines say. It can be attempted providing you are within the legal limits of your local laws, as well as it is reasonable and ethical to do so. Anti-seizure medication, topiramate, zonisamide, metformin, GLP-1 agonist, exenatide, liraglutide, antidepressant medication, bupropion, attention deficit hyperactivity drug, methylphenidate, thyroid hormones. These are the candidate agents that is mentioned in the guidelines. Now coming to the role of bariatric surgery in children, current data indicates that patient safety and weight loss outcomes for extremely obese adolescents undergoing bariatric surgery are comparable or better than those seen in adults. So it's equivalent to or even better than that is seen in adult. So no need to think that adolescent children, they're still growing, puberty is not completed. All those questions are there, but they still have the same potential, same effect like adult. Coming to gastric bypass surgery, 6 trials have been compared so far. 131 adolescent patients have been recruited. They all have a mean BMI of 51.8, reported a significant and sustained decrease of BMI after surgery. Severe complications such as anastomotic leak, sepsis, bleeding are rare. No deaths have been reported in the perioperative period, but there have been 3 long-term deaths reported. One occurring at 9 months and 2.5. Of course, these are all the development stage. So we can always perfect these things. If Banting and Best thought that insulin can never be invented, we wouldn't have insulin today. So these are all the early stages. We are at a difficult level with a steep learning curve and a steep curve. But in 10 years time, 15 years time, this is going to be the rule. Coming to the adjustable gastric banding, excellent safety profile and lower risk of postoperative vitamin deficiencies. No FDA approval for less than 18 years, but still being used, even though there is no FDA approval. 7-fold increase in the use of AGB for patients 13 to 20 years old from 2015 to 2017. So 2 studies, I'm just comparing, 200 adolescents demonstrated substantial loss of excessive weight loss, that is 37 to 63%. No deaths occurred in these studies, and the complication rate was 6 to 10%. O'Brien and other studies, significantly greater decrease in body weight, 30% BMI reduction. Reoperation, however, developed in more than 1/4 of the adolescents undergoing the gastric banding, adjustable gastric banding therapy. So, is there any rational approach? Can we come to some conclusion? Lifestyle intervention represents the core of the treatment. Nobody is denying that. That's the core of the treatment. But the question is that alone enough? Obviously, we know it is not sufficient. So, metformin, which reduces the rate of type 2 diabetes, is a valuable adjunctive. Orlistat also reduces the adult onset diabetes. Dyslipidemic patients may benefit from orlistat or metformin, which reduces LDL levels also. Sibutramine is most effective at reducing body weight, but withdrawn due to side effects. We'll watch this space, so we don't know what the future holds. Phentermine and topiramate is promising now, coming up. bariatric surgery can be considered as indicated in the Endocrine Society clinical guidelines. It is all mentioned in the guidelines. Otherwise, why would they mention in the guidelines? So it is all mentioned. Of course, it is in the early stage. So in future, we have to watch this space. Thank you.
Thank you, Ravikumar. You have highlighted that the importance where lifestyle modification alone will not be fruitful, and you need to, on a long-term basis, to add on some pharmacotherapy. It is not only to reduce the weight, but also to reduce the complications like type 2 diabetes in adolescent population. And you also told us that bariatric surgery is an experimental tool which can be tried in the adolescent population. But you also highlighted that the weight reduction with the available safe drugs is around 2 to 3 kilos. And for this, against is going to be talked by Dr. Hemchand.